can't do this. So we are the innovator and the incubator of all the great new innovations. And if you just think of the cancer therapies, all of these things, the new things that are coming out for various muscular dystrophy, Alzheimer's, they're all taking place in this country. And very few of the drugs that go into trial make it. And it's very expensive. And so we want to keep the pipeline in this country open. Countries like Canada with price controls, they do import drugs. They import drugs from the United States, or they manufacture them in Canada, but they're American drugs. And people say, oh, well, their drugs are cheaper. Well, they have price controls. But what people don't realize is that the Canadian Patented Medicines Prices Review Board decides what drugs are going to be imported at what price. And if they decide that the latest new drug to treat muscular dystrophy is too expensive, it doesn't even get onto the formulary. So there are additional costs. If Nancy Pelosi and her crew at H.R. 3 get that through, and if it got through the Senate, this would be a disaster for all of us who depend on these great new innovations. And as Frank Lichtenberg at Columbia says, for every $1 spent on newer pharmaceuticals, we save $7.17 in hospital costs. It used to be if you had a gallbladder situation, you had to have your gallbladder removed. There are costs to that. You might not make it through the anesthetic, and you have to recover from the anesthetic. There are drugs now that have supplanted surgeries, and it's so, and hospital costs are reduced as well.
Absolutely. I give the example all the time of hepatitis C. Back when I came out of school in 1980, if you were diagnosed with hepatitis C, you were going to die.
Yeah, you were going to get liver cancer.
And that was it. It was essentially a death sentence. Right. Now we can cure it with a pill. How phenomenal is that?
And people say, well, you know, that pill, you know, from the Gilead, right, you know, it's $85,000, but it does do the cure. If you have to have a liver transplant, we're looking at $500,000. So, you know, and it's hard, many times you're not able to get a liver that's a match. So it's actually very inexpensive, and you get rid of your Hep C.
You mentioned H.R. 3, and we had an alternative, we in the Republican Party, H.R. 19, which was much better and didn't have any price controls. The Congressional Budget Office, CBO, scored H.R. 3, and with the price controls, it was estimated that 8 to 15 drugs that would have come out on the market in the next 2 years would not, if we put those price controls into effect. And you know, which drug is that? Is that the cure for Alzheimer's? Is it the cure for diabetes?
Yeah. Even
if it's just one, it's one too many.
Right, exactly. And I've even seen numbers that 100 fewer drugs would be developed in this country. And you know, so many people with diseases like diabetes that are just waiting and holding on, hoping that they're going to be able to survive, and when the next new drug comes out that will allow them to be like people who, you know, have survived with hepatitis C because of the drug from Gilead.
Right. One last thing on this before we move on. You mentioned that not all the drugs that are available here in America are available in Canada or in the United Kingdom.
Right, exactly. And, you know, so people, you know, in Canada, I mean, you have to pay for your drugs in Canada. They're not only people at the very low end of the income ladder actually get free or reduced drugs, but most people pay at the pharmacy. But they often, in many cases, you know, the drugs that they are getting, because the latest drugs aren't on the formulary, they don't even know that there's a newer drug that may cure their leukemia or their non-Hodgkin's lymphoma. My uncle passed away from non-Hodgkin's lymphoma back in 2003. Now, here in America, Rituxan had been approved by the FDA in 1997. And when I talked to my cousin about my uncle with NHL, I said, well, you should go to the head of the cancer agency and see, well, what about getting Rituxan for your dad? And he did. And the head of the cancer agency had never heard of Rituxan. He got back to my cousin in 2 weeks and said, well, you know, that drug's just not available here. You can take your dad down to Seattle and go to the Fred Hutchinson Clinic there. Well, you know, you have to go over the border. It's a big deal for when you're older and you're sicker. But so a lot of these new drugs are just not available, and people don't even know about them. But they think, you know, the Canadian healthcare system is almost like a religion, just like in the UK. You can't criticize it, and yet everybody's complaining. And the older you are, the more likely you are going to complain.
So let's talk about some of the other costs, not necessarily monetary.
Right.
Wait times. You talked about wait times earlier, and the overcrowding that takes place, and in the hospitals and in the healthcare system in general.
So in Canada, as I mentioned, the average wait from seeing a primary care doctor to treatment by a specialist is 20.9 weeks, over 5 months. I mean, can you imagine Americans, if I went to the doctor and I felt I had some problem, but I couldn't even, go from my primary care doctor to getting, treatment by an gastroenterologist or whatever. It would be, I would be very upset. Americans wouldn't tolerate it. So you have long wait times, care is rationed. Take the case of my mom, who was a senior and who thought she had colon cancer. She went to the doctor, had an X-ray, and I said, Mom, and he said, I don't see anything. So I said, well, Mom, you don't detect colon cancer with an X-ray. You need to get a colonoscopy. So she said, well, you call. I said, no, I'm down in the States. You call. So she did, and the doctor told her, primary care doctor said, unfortunately, you're a senior. We have too many younger people who are on the waiting list to get a colonoscopy who have symptoms that are serious. So 6 months later, my mom had lost 30 pounds. She was hemorrhaging one morning. We got her to the hospital in an ambulance, 2 days in the emergency room, 2 days in the transit lounge, waiting for a bed in a ward. She got her colonoscopy, died 2 weeks later from metastasized colon cancer. This is how, when government sets a global budget, we spend 18% of GDP, Canada spends 11%. When you have to limit what you're going to spend, there isn't enough to go around, and so people are going to have to wait, and the people that are going to wait the most, the longest, are seniors. Right. And it's the same in the UK. Just 4,000 people, it was just revealed, went blind with glaucoma because the waiting time to get an appointment with an ophthalmologist was just too long. By the time they finally got their appointment, 1,000 of them, had gone blind.
The book again, false premise, false promise.
Yes.
And one thing that I really enjoyed was the stories, just like the ones that you just shared. But one of the stories that talks about overcrowding, Mary Louise Murphy was sweating profusely and had trouble breathing when a friend brought her to Abbotsford Regional Hospital in British Columbia on the night of January 30th, 2017, according to the CBC. She was quickly seen by a doctor, was told the 56-year-old she was experiencing muscle spasms. She was given a shot of morphine and sent home. Murphy died 2 days later on February 1st. Her experience is unfortunately common in Canada, where overcrowding often leaves hospital staff unable to devote proper attention to emergency room patients.
Well, exactly. Emergency rooms are piled high with patients. When the SARS situation was in Canada back several years ago, I mean, ambulances were having to leave one hospital and go to another to try to get room for somebody to get in to the ER. But they have what they call bed blocking in Canada, which means people who are older who are in the hospital with something, chronic, I guess you would call it, they stay in those beds, and so younger people who need to have surgeries and things, they can't get get a bed in the hospital because they're blocked by these people who really should be in a senior's home or in an assisted living facility. So it really it's just amazing how the Canadian healthcare system, the government system, works. And my very good friend of mine, Dr. Brian Day, is an orthopedic surgeon, has a private Cambie surgery in Vancouver, has been treating private patients, which is illegal under the Canada Health Act in British Columbia. He has been in a lawsuit for 10 years. This case has been in the BC Supreme Court for 3 years. The government keeps putting more and more money into it to stall because they don't want to open up the system to some private alternative. And a lot of the people that he takes care of are people who are in the government who are opposed to opening up the system. So choice and competition will solve so many of these problems. And there's no question there are some things that need to be changed in the American healthcare system, but choice and competition will bring down the cost, like in every aspect of our lives, and it will lead to universal coverage.
Another thing that outside of the monetary costs,
right.
Doctor shortage. Now, one of the things you mentioned about fewer students young people going into the medical profession and all.
Kids,
one of the things we're struggling with in Washington, D.C. right now is the high cost of education and right. student loans. Right. And certainly physicians and pharmacists and other healthcare professionals come out with high student loans. How are we going to deal with the doctor shortage?
Well, the American Association of Medical Colleges has come out just recently and said by 2030, which isn't that far off, I never thought it'd be 2020 so